All right, so actually, live, we will talk about drugs in like 2 minutes, but a couple of real quick slides. Storage, this one can kind of be a little bit comical if you think about it. We're supposed to avoid temperature extremes, direct sunlight. Increasingly, I think I mentioned at the very beginning, there are more manufacturers that are coming up with the smaller fridge things to go in medic units. Most people don't have them, but if you're running on a fire unit or rescue unit that's sitting out in the sun, it's really hard. You either sun in the summer or winter, so a lot of drugs you have to at least think about the extremes. Do understand that can affect how long the drug is effective. A couple of things we do need to think about though is usually when you look at a drug vial or syringe, it's going to talk about its expiration date, but if it's something that's supposed to be refrigerated, then there may be other data. And so probably the two best examples that I can come up with, one is rocuronium. If it's refrigerated, you're fine until that expiration date on the vial. If it's not refrigerated, it's really a month. So like at UT, where we have our RSI packs, our intubation packs, we keep rocuronium in those, but we also have an ancillary sticker that we date for a month after it comes out of the fridge. Now, unfortunately, we use rock so much that we rarely have to worry about it expiring, okay? The other one is diltiazem. So if you have cardizem that you're mixing drips with or whatever, some of the companies do make dry powder, which will be stable longer, and you reconstitute it, and boom, you're ready to go. But if you got the refrigerated vial, it's only good for about 60 days out of the fridge, okay? Now, the reason I say that is, what's the potential downside if we use it past that date? It may not work as well. Is it going to not work? We don't know. So at least those dates. Now this is a real big stretch, by the way, guys. Real big stretch. Probably 3, 4, 5, 6 years ago, I had a medic come to me, and after I'd done the class, I said, "Hey, ours, we're keeping, cardizem, ... And I said, well, so our medical director said it's fine. I said, well, I'm like, with all due respect, the medical director has been saying they know more than the FDA and the manufacturer and everybody else, which I was obviously being tongue-in-cheek. So here's and by the way, I'm not aware of any test cases for this, so don't think this is a sky's falling. But let's say I've got an AFib RVR patient, and I have diltiazem on my rig. I know it's 30 days past its out of refrigerator date, but I keep it on my truck, and my medical director said that's fine. And I don't get the effect I need, and I'm billing for that call, and it's a Medicare patient. What have I just committed unknowingly? Medicare fraud, right? So, again, I'm not a legal kind of person, but just understand that there are some implications we need to at least think about.
So,
okay, yeah, go ahead.
Cardizem's supposed to be refrigerated?
It depends. There's a powder form, so two different things. The one for the bolus, there are some powdered ones that are not refrigerated.
Right.
There's already reconstituted ones that generally have to be refrigerated. And out of the fridge, their expiration dating comes down to about 60 days. Okay, that's for the liquid. Now, if you're using there's a thing called an Advantage system.
Right.
Okay, that you've got the fluid and the thing screws on top. That's just a powder, and those are stable out of the fridge until you activate them. Okay, so it's just one to know. And again, those products can switch back and forth. We're again in the inpatient setting. We're a little spoiled because they're in the fridge, and then we send the drips up from the IV room, and they just activate the powder. But there are dosage forms out there that are the powder, and that way you don't have to worry about you don't have to worry about the refrigeration.
No, we're carrying injectable cardizem out of the fridge, and there's not been any mention of that.
Okay, what I would do is I would check whoever does your supply, when they get the box that has the package insert in it, I would actually get that out and look, and it'll even say in there, stability outside the refrigerator is X number of days. And I will say this in fairness, Steve, I'll say this in fairness. I think a lot of it is just, people just aren't aware.
Yeah.
I mean, and I get that. I'm not saying people are doing anything unscrupulous. But once you have that information, I do think the onus is on us then to make sure we're not extending it out to where we might give a subtherapeutic dose to somebody, right? So so those are a couple examples. Drug security, I preach to the choir here. You know, check with the person you're coming off shift with. I know that they've run all night. They want to get home. Check your marks, right? Again, I'm preaching to the choir here. And then this last thing on this section, obviously protocols, not just when you're going to give it, how you're going to give it, and then stuff we go through today, we're not going to talk about everything. For instance, again, we're not going to talk about neonatal, we're not going to talk about high-risk opioid, okay? We'll kind of talk as a kind of overall. Okay, so finally, thank God, finally we're going to talk, thank goodness, we're going to talk about some actual drugs. So this is where it is helpful to think overall class, overall effect, and then think about nuances about when individual agents are going to be helpful, okay? So I would say that vasopressors are one of those meat and potatoes kind of things for critical care. This is when you start getting into kind of the fun stuff. Not for the patient, because if they're having to get them, they're not in good shape, right? So when we think about vasoconstriction, well, first let's do a real quick review of Physiology 101. 1%, that's right. Okay, so when we think about the sympathomimetic system, it mimics the sympathetic system, right? That's all that means. It's a fancy word for saying it acts like your sympathetic. Fight or flight, right? Fight or flight. Now, these receptors live all over the body, but for our purposes, we're going to kind of focus on what they do for us, okay? So like alpha-1 is, and by the way, if you look like, and sometimes they'll have these in your textbook. So if I take a blood vessel, it's called a sagittal view. So I slice through the vessel, and I'm looking through the blood vessel. When I stimulate that alpha-1 receptor, it causes vasoconstriction, okay? So for our purposes, alpha-1 is vasoconstriction, okay? Now, real quick, alpha-1 also, if you ever taken Sudafed for sinuses, it's an alpha-1, okay? It constricts the vasculature in your nasal passages to allow you to breathe better, okay? You sometimes use an alpha-1 blocker. So as men get older, the prostate gets bigger, they take something like Flomax. It's an alpha-1 blocker that affects the detrusor muscle and relaxes it, okay? So that's just those kind of things, all right? So vasoconstriction. Beta-1, we're going to talk in terms of cardiac. Now, for cardiac, we can think of the heart in three ways. Chronotropic, time, okay, so rate. Inotropic, or squeeze, and dromotropic, or rhythm, okay? So I need to remember that because when I stimulate beta-1, I may get the benefit I want of inotropic, but I may also get chronotropic effects, and I may get rhythm effects, okay? So cardiac. Beta-2, for our purposes, we're going to call it pulmonary, okay? So beta-2 agonist, albuterol, you know, bronchodilates. It's also used, we use beta-2 agonists for like smooth muscle relaxation for preterm labor, like terbutaline, stuff like that, okay? And then we have the vasopressin receptor. And the reason I drew a line here, these are all part of the sympathetic nervous system, so fight or flight. And we don't always hit just the one receptor we want, okay? V1, vasopressin receptor, will cause vasoconstriction but it won't cause an increase in heart rate or increase my oxygen demand. So that's one of the things, if I use epi, right? Epinephrine does all three of these. But what can epinephrine also do? It may increase my oxygen demand because I'm tacking along, right? Okay? So that's where, so vasopressin, you'll mostly see it used anymore in more like sepsis, okay? You'll see it used in the ICU quite a bit as a vasopressor in those settings, okay? So, now, why isn't the screen changing? Well, it's because I didn't change it. Okay, so there are multiple tables in your book, and we'll hit some of those as we go through. But when we think about vasopressors, phenylephrine, which is more of a pure alpha, okay? It's really a pure alpha agonist. Epinephrine, both of those do kind of alpha and beta, okay? Vasopressin, I just talked about, okay? Now, they list methylene blue. Methylene blue really is more, quite frankly, for restoring vascular tone like in cardiothoracic surgery. So it's not like you would, I mean, I see it more used for like a diagnostic dye. Sometimes they'll run like a gut or the bladder, and they'll use methylene blue. And it's also, if somebody developed hemoglobinemia, it's actually an antidote for that. So they list that in your text, but I wouldn't really like rack my brain too much unless you were, again, working in a cardiothoracic unit. Now, push dose pressors, I'm just going to mention this real quickly. This has gotten a lot of press, and we do them all the time. So let's say we're intubating somebody on our intubation team, and then, of course, they're tubing them, and they tickle that vagus nerve, and they get hypotensive or whatever. As long as they don't get bradycardic, a lot of times the anesthesiologists go, hey, you got a neo stick. It's just phenylephrine. It's a diluted form, and that's the key word, diluted form. And then we just give little tiny doses. Or we also like those while we're mixing like a lever-fed drip. While it's taking a minute to mix that, they can just sit there and do vasopressors. The key thing though is it has to be diluted. So you can also make them like an epinephrine. You can do a push dose epi, but just make sure you're diluting it like out of the cardiac epi, not anaphylaxis epi, because it's all about concentration. Okay, and we'll leave kind of that.
Question about the push dose here.
Yeah.
So, we have, most of us have dopamine, and we can mix epi, but we don't have to put them on pumps, which to me is not good. And I had a patient the other day that I was push dose epi for multiple minutes.
Yeah.
To get, because I'm not going to start an epi drip, because I can't really get a good calculation.
I get that.
But I can give 20
And you can do it
mics.
every 2 to 3 minutes. Absolutely.
Yeah, to maintain that.
Absolutely. It's, I mean, and that's the nice part about it, is that if you either, because, you just don't have enough hands at that point in making the drip, and if you're over here mixing the drip and they're getting unstable on you, that's the nice part about those. And just real quick and dirty for an epi push dose, if I've got my 10 cc saline flush, squirt out 1 cc, and then I take my 10 cc cardiac epi, right? They don't call it 1 to 10,000 anymore. 1 milligram in 10 mLs. Okay, so that's 100 mics per ml. Okay, so then I take 1 cc, put it into that syringe, and I now have 10 mics per ml. Okay, and I basically give 10 to 20 mics, so basically a half ml to 2 mLs every couple of minutes, like Stephen's talking about. Pretty darn nice. Okay, and that's where push dose, but dilution. Okay, that's the take-home point there.
My max dose on that's 0.2. I can give up to 2 micrograms. Much.
Is that your drip or your push dose?
Just push dose.
Yeah, because it's done, that would be a pretty low dose, because it's usually like 5 to 20 is usually.
And I've done it one time
Yeah,
during COVID, because
Yeah, yeah, oh yeah,
Ambulance.
absolutely, yeah.
It's the only
But
thing I've
that's,
ever done.
there's a lot of good stuff out there on push dose, but the biggest thing that everybody underpins is just make sure you dilute it, okay? So, in angiotensin two, there are some angiotensin two agonists. Those are not a pre-hospital thing. Matter of fact, we don't use them a lot in hospital. There were some that are on investigational, so we'll kind of leave that to the side just for, that's where if you think about like angiotensin receptor blockers, like valsartan, losartan, they're blocking angiotensin two, which is a potent vasoconstrictor. That kind of makes sense, okay, from a receptor standpoint. Now, one thing, has everybody got this up here? When we are talking about, oh, by the way, phenylephrine, I mentions a potent alpha-1, okay? Every time I do that, you know, I'll back sagittal view. I can get a reflex bradycardia with phenylephrine, so that's at least something to be aware of. If I've got somebody that's profoundly hypotensive and their heart rate's already like 60 or 55, I probably don't want to give them phenylephrine because it could worsen that heart rate. Okay, it's just a reflex, and that's why it's called that reflex bradycardia. Okay. Now, most of these we try to titrate to a mean arterial pressure. Okay. At least the figure that I usually see is 60. Some people will say 65. Okay. Mean arterial pressure is systolic blood pressure plus 2 times the diastolic blood pressure over 3. Now, thankfully, most most monitors and things like that now do this for you. Okay, if I had to do that, I'd be like a monkey doing a math problem. Just to be honest with you, I'd be, oh, give me about 5 minutes to write this down on a piece of paper. But that's how it's figuring that out. Okay. What do we need to ensure we are either doing or have done before we give a vasopressor? Fluids, okay? I need to either make sure I've got fluid. Now, granted, somebody's hemodynamically stable, maybe hemodynamically stable because they have no volume, but it could be neurologic, it could be they have no pump, they may be volume overloaded, but I've got to at least troubleshoot what's going on. And so the example I always give, so I'm washing my car, I'm too cheap to buy a good nozzle, so I've got my little cheapy Walmart nozzle, right? I've got soap all over my car, it's 95 degrees outside, and shockingly, my 99-cent Walmart nozzle breaks. Crap. So how am I going to increase pressure once I take that nozzle off?
Put your thumb in
So what does it do? It increases pressure. Now, what if somebody tries to play a joke and they turn the spigot way down and I put my thumb over it? Is that going to work? No, because it doesn't have volume. That's how you can think about vasopressors and fluid resuscitation. If I'm sitting there just cranking the crap out of my vasopressor and it's not doing any good, maybe because I don't have any volume, okay? And I've seen that a few times, and that's not to be like a smart aleck. I'm not in the ED a lot anymore. Years ago, I went down with our team, and this guy's suction canister was about to overflow with dark, copious, black stuff coming out of an NG tube. I don't diagnose. I'm not the smartest or sharpest crown in the box, but I'm like, probably a GI bleed, okay? And they were just saying, well, he's not responding to the pressure, blah, blah, blah. I was like, did y'all give me fluid? Oh, yeah, let's give some fluid boluses, okay? So it's in trying to lead, and by the way, in team dynamics, that's one of the things I really like about this American Heart has gone towards like the pit crew thing and a lot of the feedback stuff during codes and stuff. That's what we should do all the time. Hey, have we done this? Okay, yeah. It's not questioning somebody, it's confirming we're all on the same page, right? So that's one of the things I would encourage. Okay, so that's one of the things we're gonna look at. Now, if this is actually, by the way, this picture is actually from radio contrast dyes, so this is not actually from a vasopressor, but the point they're trying to make is, so let's say you've got them on a pressor, you're doing a critical care transport, and all of a sudden, the pressure's kind of dropping out. It's not responding as much anymore. common things being common, if I do have a pump, which I hope I do, look at that site, you know, is it extravasated? Okay, so the risk of an extravasation of a vasopressor is that not only does it cause your vessels to vasoconstrict where you want it to, it can then cause tissue necrosis. And so that's when you'll literally, and what we would certainly do in the hospital, so because it's being caused by an alpha-1 agonist, I need an alpha-1 antagonist, and we'll literally take phentolamine, which is an alpha-1 blocker, diluted, and sit there and work it around into the tissue to help prevent it from being necrotic. Doesn't mean it'll totally prevent it, and sometimes they have to end up, some of these can be really, really bad, to where they have to end up having plastic surgery and debridement, but we've got bigger fish to fry at the moment because you've got to be able to get, ensure that they are getting vasopressor if they're unstable, okay? So again, that picture's a little bit out of context, but at least it does make the point, okay? All right, so that's vasopressors, okay? So now, we're gonna move into inotropes, okay? So this one is, so vasopressors overall, think alpha, okay? Alpha-1, okay? And maybe vasopressin. For inotropes, think beta-1, remember? So beta-1. We mentioned inochronodromo. So just understand, I may increase my pump, but I may get tachycardic and I may stimulate dysrhythmias. That's probably, quite frankly, the biggest criticism of dopamine, is not that it's not a good vasopressor, but it's just that you get a lot of tachycardia, okay? They say here, I mean, side effects from tissue headaches, which I'm not sure, you know, arrhythmias. Basically, this is one to think about the extension of your pharmacology, right? Think about tachycardia and that kind of thing. So, and we'll talk specific, the tables really address this more. So dopamine does different thing at different doses, okay? At the lower doses, it actually hits what's called a dopamine receptor, which really probably, and there's debate on this, maybe it perfuses the kidneys a little bit more, we're not real sure. Then as you get into moderate doses, it's more alpha, really beta at the moderate doses, and then high doses is more of a vasopressor. But it is titratable, okay? And that's key with all these drips, you titrate them to effect. Dobutamine, so dobutamine and milrinone, so dobutamine does beta-1. It also has a little bit of beta-2, so you get a little bit of afterload reduction. We're gonna come back to that concept in just a second. Milrinone works on the phosphodiesterase system, so it's not a sympathomimetic, but it increases pump. It also decreases your afterload, and you'll sometimes hear dobutamine and milrinone not just referred to as inotropes, but inodilators, okay? So inodilators, which, if you think through it, I may get a drop in high pressure, okay? So that's one of the things to think about as we go through these. Now, these charts really kind of just take you through the med uses, which kind of are intuitive if we're in the inotrope section, right? How they work, and we've kind of talked through those. They're really IV or IO, except milrinone, at least this point is IV. And the side effect profile, which are mainly going to be extensions again of your pharmacology. They mention this, which is kind of redundant. These people need to be on continuous hemodynamic monitoring. That kind of makes sense, okay? All right. Now, we're totally switching gears here. Before we were talking about vasopressors, increase my blood pressure, inotropes to increase my pump. So now we're totally switching gears. We're on the other end of the spectrum here, okay? So we're going to talk about vasodilators and antihypertensives, okay? Still manipulating a lot of the same receptors, but so this concept, so blood pressure equals cardiac output times systemic vascular resistance, and then cardiac output is heart rate times stroke volume, okay? Now, real quick, the reason this is important, kind of explains why antihypertensives work, okay? So if I decrease my systemic vascular resistance, which is something that, you know, basically actually causes the vessel to dilate, so like a calcium, like amlodipine, hydralazine, it's physically decreasing resistance for my blood pressure. My cardiac output, heart rate, and stroke volume. So this also helps you understand how some of these antihypertensives work. A beta blocker decreasing my heart rate, which is then going to have an effect on my blood pressure. It's not the most profound effect, but it does affect it. Stroke volume, diuretics. That's why hydrochlorothiazide, chlorothalidone, whatever, I'm decreasing my stroke volume, and then decreases my cardiac output, decreases my blood pressure. Okay? That's really what we're looking at. Now, the other terms to be familiar with, I already gave the warning, I'm a terrible artist as I am a draftsman. Okay? Here's the heart. We'll call that a heart. Everything coming in to the right atrium is basically going to be termed preload. And the pressure that comes out of the left ventricle, I know it's supposed to be down here, but anyway, give me a little grace, is going to be afterload. Okay? Okay, so a lot of these vasodilators may have more focus on one or the other, more preload or afterload, but to most effect, they do both, okay? Which is why it will affect your pressures, okay? The second bullet point is kind of redundant, you know, why we're using it, how the patient responds, cost, and I know that shockingly, if we're lowering the blood pressure, the big side effect is hypertension, right? Okay? But give you an example. So let's say I have a patient that has diabetes, hypertension, and they have heart failure, reduced ejection fraction. Well, that's where I really, really, really like something like an angiotensin receptor blocker, or even the combination agents that are out there, because I will decrease my afterload. Okay, I will help my kidneys, which diabetic nephropathy, and I help my blood pressure. So that might be a great place to pick that agent. Okay, and so that's kind of just one of the examples. Now, potent vasodilators, and these are more direct. Okay, these are the ones that definitely affect your afterload for sure. We don't see it used a lot anymore, but sodium nitroprusside is a direct vasodilator, phenodilator. These folks absolutely have to be monitored. This isn't one you check the blood pressure in 10 minutes. This is one you're constantly checking it because it will just plummet it. One of the reasons we don't use it anymore is we have other agents that are really effective, which I'll talk about in a minute. The other one is if you have renal dysfunction or you're on high doses, then actually you can accumulate a chemical called thiocyanate that's similar to cyanide, and you can actually get cyanide toxicity, okay? So that's one of the things you gotta be careful with. Obviously, we know nitroglycerin, right? Hydralazine, effective vasodilator. Now, you remember when we talked about phenylephrine, and we talked about how it can cause a reflex bradycardia? So hydralazine can cause a reflex tachycardia. So if I had a person who was hypertensive, but there's somebody that has like AFib or PSVT or something like that that's not well controlled, and I gave them hydralazine, I could actually worsen that, okay? And that kind of has to back to our little equation over there. If I decrease my stroke volume for systemic vascular resistance, my body wants to actually maintain my blood pressure. I've gone too low. One of those mechanisms will be heart rate, right? If you go, again, today it's very nice outside. Let's say it's 95 degrees, you've been working all day, you not be able to hydrate, and you get kind of dehydrated. What's your physiologic response to maintain your cardiac output?
Heart rate.
Tachycardia, right? That's one of the ways you can be able to tell. Okay? Now, clovidipine and nicardipine, they're both calcium channel blockers. They're in the same class as like amlodipine or nifedipine, but they're just intravenous, okay? Have you guys already done your neuro clinicals?
No.
Not yet? You are still doing those?
Yes.
In neurocritical care? You'll probably see a lot of clovidipine used there, Cleviprex. Very effective. Onset is nice. It doesn't plummet your blood pressure most of the time. It's pretty predictable. One little caveat, it's in an emulsion. It looks like milk, so you can't really tell a lot of drug interactions and stuff with it or incompatibilities. But you will definitely see it used. In the interest of time, and I've tried to make comments as we go through,